Hi, I'm Andy Matthews, a hematology oncology instructor at the University of Pennsylvania. I'm here to discuss our group's abstract, Real-World Effectiveness of 7+3 Intensive Chemotherapy versus venetoclax and hypomethylating agent in newly diagnosed adult patients with acute myeloid leukemia. Standard of care therapy for AML has remained the same for the last 40 years. It's been intensive chemotherapy induction with a 7-day infusion of cytarabine and 3 days of an anthracycline treatment, so-called 7+3. Historically, median overall survivals have been around 14 months, 2-year overall survival around 35 to 40%. Recently, venetoclax and hypomethylating agent combination has achieved similar results in older, frailer populations unfit for intensive chemotherapy. Given no prospective trial comparing these two approaches, we undertook a national retrospective multicenter study to do so. Our goal was a real-world population of patients with clinical equipoise between 7+3 and venetoclax with hypomethylating agent. Thus, inclusion criteria was restricted to older adults aged 60 to 75 without major heart failure or chronic kidney disease to try to encompass transplant-eligible patients. We included all risk groups and all mutational statuses. Utilizing two data sources, the Hospital of the University of Pennsylvania electronic medical records and the National Flatiron Database, we identified 312 and 488 patients receiving 7+3 and venetoclax HMA. Among the 488 patients who received venetoclax and a hypomethylating agent, and the 312 patients who received intensive chemotherapy with 7+3, there were major differences in baseline characteristics. The venetoclax and hypomethylating group were older, more likely to be treated in the community, more likely to have secondary AML, had higher adverse risk disease rates by ELN 2022 classification, and had more comorbidities and more adverse risk mutations such as TP53 mutations. In short, the venetoclax HMA patients were older, sicker, frailer. As might be expected regarding adverse events, infections, transfusion, length of stay were all higher with 7+3 as initial therapy. However, we also examined total days of interacting with the healthcare system from diagnosis to death or end of study period and found that overall, patients receiving 7+3 had 68% of days free from the healthcare system versus 54% for venetoclax and HMA. For the primary outcome of overall survival, patients who were selected by their physician to receive 7+3 as initial therapy had significantly longer overall survival of 22 months versus 10 months for ven-HMA. The hazard ratio of 0.53 and 95% confidence interval 0.4 to 0.6. 1-year overall survival was 70% versus 44%, and 2-year overall survival was 48% versus 25%, both favoring intensive chemotherapy. We conducted multiple sensitivity analyses, and while there's a smaller subset of ven-HMA patients with strong outcomes, even after adjusting for missingness and imbalance in baseline characteristics, patients receiving 7+3 had longer overall survival. These adjustments appear to account for about half of the difference in overall survival, but the results are still compelling with much longer overall survival for 7+3. That said, there's several limitations to this retrospective study. Selection bias, unmeasured confounding, and crossover all may play a role. Overall, we found that patients selected for intensive chemotherapy with 7+3 had superior overall survival compared to patients selected for venetoclax HMA. For my personal clinical practice, this study highlights that for carefully selected patients, traditional intensive chemotherapy with 7+3 can lead to superior overall survival. It's strongly important to consider the role of intensive chemotherapy in transplant in older patients with AML. Our ability to identify those patients most likely to benefit from less intensive approaches should be an ongoing focus of our research and prospective trials.